Hi, everyone. Just giving you all a few seconds for people to join, and then we'll go ahead and get started. All right, so thanks for joining Strategies for Optimizing Medical Problem Lists. My name is Jordan Liebowitz, and I'm part of the marketing team here at IMO Health. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available for future viewing, so be on the lookout later this week, and we'll send the recording to you. Today, we have our Chief Clinical Officer at IMO, Dr. Stephen Rube. And as mentioned before, if you have any questions or comments while our team is speaking, type them into the Q&A box on the bottom of your Zoom console, and we'll get them answered in our Q&A session. So without further ado, I'm going to pass it on over to Dr. Rube.
Thank you very much, Jordan. Good morning, good afternoon, or good evening, depending on your time zone. Thank you very much for joining us today. The title of the webinar, Strategies for Optimizing Medical Problem Lists, a fancy way of saying the problem with the problem lists. Anyone who's practiced medicine since this great journey with the electronic medical records going back to the 70s and then with meaningful use in the early 2000s, have known that there's been major advancements and benefits from when we've gone digital, from the old days of the paper record, not to date myself, but the old days of searching for paper charts. But one of the things that we seem to still be struggling with is the problem list. The law of unintended consequences, you would have thought that the problem list would be one of the major benefits of going electronics, and in many ways it was. But certain problems such as dating, problems that were automatically defaulted to the date of entry, the way they were categorized, things being automatically added, problem reconciliation, governance, really are problems that have really, not plagued us, but we've struggled with trying to deal with. There have been approaches, some very good, some not so good, some have worked, some have not worked as well as others. In no way, shape, or form is the solution that you're going to see today proclaiming itself to be the panacea to solve all problems with the problem list. And what we did was we posited certain things and we instituted certain solutions. And then you'll see, as part of this webinar, we created a bit of a challenge to test some of these theories to see if they were valid or not, or even if the study was valid or not, which revealed some interesting things as well. So we're going to start with a little bit about who we are at IMO briefly, talk about the problem, the solution. We'll talk about that challenge, that study that we did to try to tease out some of the issues and the solutions and whether they worked, what's next, and hopefully we'll leave some time for questions. As I've said in the past, anyone who's heard one of my webinars, I'm not a believer in death by PowerPoint, so this will not be a 600 PowerPoint webinar. We'll go through it. And as I said, I do plan on leaving quite a bit of time for questions at the end. So for those of you not familiar, who are we, IMO? We've been around for almost 25 years at this point. Actually, I think this year is our 25th anniversary, doing the math. And what we do is we provide clinical terminology to most of the EHR vendors in the United States and outside the United States. We do other things as well. We've expanded into the data normalization fields and the data quality fields as well. But certainly we made our bones by providing the major that was a Freudian slip, the major EHR platforms with terminology that is both kept up to date and standardized. It allows for both use within that electronic record platform as well as interoperability between them with no loss of fidelity. As I said, we're growing. We're approaching 300 people here at IMO. Our main campus is in Rosemont, Illinois. We do have offices in California and Texas as well. And as I said, in addition to the partners you see on the left of this slide, we're embedded into well over 100 other applications. Well over 500,000 physicians on a daily basis touch our content. Most major facilities, acute care facilities, hospitals, 4,500 of them in the United States use our terminology. And the stat on this slide really that I'm most proud of is the 99% retention rate. Basically, people do trust us. We've become the trusted partner for providing clinical interface terminology. And we'll discuss, a little bit what that means as far as, providing that embedded within these very robust electronic medical record platforms. So let's define the problem. One thing I didn't realize, this was very interesting. I did the exercise myself, which I often, charge people to do, is type in the problem with the problem list, and you'll get many different results. I guess Google has an upgrade now where, if available, they will give you an AI response. And although we all know that AI can sometimes drink a little bit too much with lunch and hallucinate at times, this response was actually fairly good. One major problem with the clinical problem list is that they become cluttered. This can happen when there is an inadequate reconciliation during admission, transfer, discharge. Once errors occur, it's likely to remain. That's the governance issue, right? Because there are not good oversight and governance policies. This clutter can make the problem list unreliable. I was going to say also unreadable for clinical decision support or analytics. That's actually a fantastic response by our friends in AI, and I'm going to give them credit on that one. We do hear some of the common complaints as well from humans walking the planet, that they're not organized in any meaningful way. They become cluttered in mainly three areas, and we're going to talk about this: duplicative problems, outdated problems, and problems that have evolved into other diagnoses. And again, the governance and reconciliation issue is one that I'm not going to claim to have solved, but I think by some of our solutions, we have at least provided a way for organizations to deal with the governance of the problem list. So the impact of an inaccurate problem list, again, this cannot be overstated. Back in the days of the paper chart, the problem list, or what we used to refer to as the face sheet, was really the way that I familiarized myself very quickly with the patient. I referred to it as the medical fingerprint of the patient. It's how I would know what was up to date, what I was dealing with, what other physicians were dealing with. And if I didn't have an up-to-date face sheet, I was really at a disadvantage, or I would have to go through the entire chart to kind of tease out what the problems were. So as a clinician, as a family physician, it really was imperative that I had accurate and up-to-date problem lists. So right off the bat, the first list, and we should never lose sight of this from a clinical point of view, is it's a patient safety issue. There are things on that list we must know about. It's important that I know if you're a diabetic, or if you have clotting issues, or even social issues such as what your DNR status may be, or and so on. There's so much information that is critical to patient care and patient safety. Clinical decision making, another important point, that if I'm going to do anything, treatments, as we all know, from everything from prescribing medicines to ordering tests to how we approach other illnesses, really are dependent on us understanding the medical conditions of any individual patient. Nowadays, there are obviously financial issues as well. We know that a list of HCCs that must be addressed. The severity of how sick a patient is often determined by how up-to-date a problem list. So an underrepresented clinical situation for a patient could result in lower reimbursement in either a capitated or a risk-based situation. There are administrative issues. Many institutions have resorted to hiring people to go back and spending large amounts of capital that is not readily available in order to bring these problem lists up to date. While some of those efforts are admirable, they are never as effective as the clinician being able to keep that problem list up to date themselves. There are legal and malpractice concerns. There was one study that showed up to 40% of medication errors can be traced to inadequate handoff and reconciliation. And handoff and reconciliation, in my mind, is directly tied to the problem list, because that is the way I would hand off a patient to another physician. And there are others. These are just some of the highlights that we hit as far as the impact of an inaccurate problem list. So what were some of the early efforts to attempt to address this? Well, rightly so. The idea was, well, we must categorize the problem. So before categorization, problems were added mainly in one of two ways. They were either added alphabetically, probably not a great idea, or they were added temporally. They were added in order of which the person put them in, or for how long the disease has been around. So Neither of those proved that effective. It was very difficult to identify problems that should be lumped together or evolving problems. So the idea was to come up with categories to place these in, and that would certainly make the display easier to digest. The problem is that the categories were often nebulous and not effective from a clinical point of view. Here's an example of a list of problems taken from a real medical record, a real chart. And you see the problems in yellow, and the category they were all placed in was other. And one study had it anywhere as high as 40% of the problems ended up in other, but the average was around in the high 20s to 30% of problems could end up in other. And some of these seem fairly straightforward. Blood and urine, I would put that in urologic, hematuria and so on. So you see both from a SNOMED coding, ICD coding, and even clinical term that a lot of these efforts had difficulty finding a home for many problems. And I would argue that having that many terms in other is a bigger detriment than having the list not categorized at all, because you fall under the false assumption that the list is categorized when really it's not. So one of the things you're going to see in our solution, and I'm going to give you a little glimpse before we go into the full solution, is that was the first thing that we decided to do, was we decided to look at categories and say, well, we're not going to define them by a body system or necessarily even the way SNOMED does, because SNOMED is great, but SNOMED is really a collection of complicated hierarchies, and there's a lot of diagonal lines, and this needed to be a much simpler process. And what IMO came up with was a collection of what we called clinical categories, in which we asked ourselves the basic question: what type of doctor would most likely be seeing this patient, would be primarily responsible for this patient with this diagnosis? And we were able to categorize well over 90% of our content, which in certain packages is approaching 1 million terms. And we were able to place them in a single category. Now, did everybody agree on that category? Absolutely not. Are we open for discussion? We are. But we do have to at least explain our logic and find one home and only one home. Problems that could exist in more than one home, if you did that, would also bloat the problem list and make it very confusing. So the first tenet was a problem needs to be in a category, and it needs to be in one and only one category. And an example of this is something such as, in this case, hematochezia, a common problem. It ended up in this situation in one EHR's example and other. This EHR has decided to go with IMO's categories for the most part, and we ended up putting it in gastrointestinal and abdominal. So what does the solution look like? Well, we call it IMO Core, and this part of IMO Core is problem list management. And problem list management attempts to attack this problem from a few fronts, but problem list management tool that helps clinicians organize problems into intuitive disease categories and declutter the list to make it a relevant, clinically meaningful tool. So we try to address a few of the bullet points and more. Obviously, physician efficiency really does talk. We talked about patient safety, but physician efficiency is part of that as well. Physicians need to be able to see patients and move efficiently. And if your time is not used wisely or efficiently, it is not productive, and it can lead to errors, or at least not optimizing the clinical care that they're receiving. You need to be able to rapidly process a list, rapidly and accurate. And as I said, this provides better clinical care, optimizes your time. Finding unaddressed HCCs to improve RAF scores. We don't like to talk about it. It's the dirty little secret, but hospitals run on financial metrics, and this is one of those that's very, very important. Large sums of money can be left on the table when hierarchical condition categories are not addressed properly. I think I stumbled over hierarchical. Better patient satisfaction. It's a point of patient confidence in their physicians. When someone's not searching going, are you a diabetic? What was your blood pressure problem? I don't remember. It certainly instills a sense of confidence when a patient feels that their doctor really does understand their problems deeply and does not have to search for it, and so on. So we divided our solution into two parts. the challenge that we spoke of really deals with the first part here, the effective display. We will speak about improved content as well, realizing that that was not something that we built into this initial study that we'll talk about near the end of this discussion. Effective display. We had to come up with a way that someone could quickly look at the list, understand the groupings, understand the problems, why they're in those problems. And then we even came up with a way that these electronic medical records, be it Epic, Meditech, Cerner/Oracle, are very complex pieces of software. They're fantastic at what they do. They really are impressive, and I mean that sincerely. But they are deep and they are big. And sometimes finding the data that you need can be difficult. Problem-oriented filtering is a way to highlight a problem on the problem list and have the EHR bring forward those relevant, medications and labs, and hopefully in the future, procedures and even notes that are related to that problem. It's been received very, very well, and it has been shown to save time and improve the information gathering part of things. So really improving that display was really the first problem we tried to tackle. People came up to us and said, great, everything's in a beautiful category now, but the problem list is still redundant, repetitive, and bloated. Please do something about that. And we labeled this a cleanup effort. We need to improve the content. We need to be able to intelligently read the problem list and come up with ways to reduce the amount of clutter in a way that we're not making automated decisions. Part of our, deep-seated belief is that humans really need to make the final decision. But if we could tee up suggestions in a way that would make it very easy for an individual to clean up a section or the entire problem list, that would be very beneficial. So we were trying to identify ways to remove redundant, outdated, and duplicative terms, and gently alert when there were opportunities for cleanup without being too intrusive into the clinical workflow. And we'll talk about that cleanup of a portion of the list as opposed to the whole list when we touch on the governance of the problem list, because that is very crucial to that. All right, so let's talk about some of the ways that we improve. So we talked about just the naming of the categories, that we came up with categories that we felt were more clinically relevant. And in this example here on the screen, you could see some of those. When you had a body system sort, you had no category for advanced directives and notes. You had no categories for coagulopathies and thromboembolic problems. You had no categories for routine health maintenance. These are very, very important. In fact, we chose as a default to float advanced directives and notes to the top of the list unless someone chooses not to. So what you see here on the screen is an unsorted list on the left, and then the option of two different displays. So the first one I've been talking about is really that clinical category. But we did hear from a lot of medical specialists, more so than the primary care physicians and clinicians, was that they were really interested in a specialty sort, something that would really take the problems that they were interested in and float those to the top. So we did come up, I believe we're approaching 30 different specialties right now, where we can provide on a user-by-user basis, depending on the functionality of the EHR, and how they could view this from a specialty sort point of view. This was often really well received as well, and for the most part, institutions have the abilities to set this view on a user-by-user basis. This solution, this view, is deployed in two different ways. In most of the EHRs, it can be employed natively as content, using the hooks of the EHR application that are out there, or it can be deployed as a Smart on Fire application, or a combination of both. We have seen it deployed in all three of those different ways. Here's an example of a application using both native categorizations as well as a Smart on Fire application to do the problem list management and cleanup. On the left, you see the native problem list that exists with the IMO categories and everything categorized. the features and functionality are still the same that were native to this application. So if you were able to know how to use this problem list yesterday, you would know how to use it the next day. The change was when there is an alert that says you may have cleanup possibilities, you can launch this Smart on Fire app on the right, which is basically a worksheet that allows for cleanup. Now, this is interesting. The cleanup exists, as I said, mainly in 3 different areas. One is outdated problems. Humans should not be pregnant for 3 years. You should not have an acute otitis media for 10 months. These things need to be addressed, and either the diagnosis changed or moved past medical history. The second category is true duplicates. Best example there on this list is ALS and Lou Gehrig's disease. Those are clinically the same. And the third was the more difficult, was related problems or evolving problems. Problems can be related, just differences in specificity. One person charted breast cancer, the other person charted breast cancer metastasized to axillary left lymph node. These might be both representing the same disease in time, yet one person, maybe not an oncologist, chose to document it with less specificity. The other example is the breast mass that becomes breast cancer, that becomes estrogen receptor positive breast cancer as an evolving disease. They have different codes. Things such as SNOMED have difficulty seeing evolutions as that because it's handled post-coordinated as far as things like staging. So it would not see a difference between stage 2 and stage 4 breast cancer. So using SNOMED alone to find these evolutions did not prove adequate. These cleanup functions were received very, very well, as I said, and they did not seem too obtrusive. And as I said, I'm going to touch on the governance here. You have the problem of the primary care physician versus the specialist. The specialist might say that the primary care list is the primary care physician is responsible for the list. The primary care physician would say, I'm not familiar with those, say, cardiovascular diseases as deeply as the cardiologist is. They should clean up. Well, what this tool allows is for people to clean up just their section if they want. We actually saw this happen organically. We saw it a lot in the orthopedic surgery field, where orthopedic surgeons were seeing 10 different versions of back pain and lumbar radiculopathy. And it was very easy when all of these were stacked up next to each other to just clean up their section. So while it doesn't answer the governance question, it does allow for each individual to clean up their section, as well as primary care to have a view of the entire list. So we wanted to test some of these theories and some of these solutions, and we came up with something called the IMO Core Challenge. And the IMO Core Challenge was not designed to test every part of the solution. It was really focused on, can the improved categories and the improved appearance of the problem list aid the physician in efficiently identifying problems, and really I come up with a more satisfying experience when dealing with the problem list. We did not test for positive impact on reimbursement for this study, but we felt even just trying to prove that this was a benefit would be an interesting task. It was a tall order because, as we know, medicine is not practiced in a lab. And to get real data, it would have to happen in the real world. And we'd have to use, real physicians looking at, real problem lists. And so we tried to design a test that would come up with that. And our theory was, if this was an old problem list, and this one, as you see, is categorized alphabetically, and we would ask questions like, identify all the neurologic problems, identify all the cardiology problems. How many duplicates are there on this list? It would be very difficult to do from a list from this. It would take certainly a bit of time. So if I said, what are the 5 obvious cardiac and vascular problems on here? It might take a second to identify them. Find me the related problems. And you see I've highlighted those in blue. It would take a while, whereas if you looked at it in a list that was more, where the display was more intelligent, you would be able to say, find me the 3 gastrointestinal problems. And assuming you could read the names of the categories, you could very easily find the 3 gastrointestinal problems. So that was our theory. Could we create a study that would test for this, presenting different problem lists, asking different questions, about that problem list, asking them to identify certain problems, and could we, extract any benefit, any real statistics that were beneficial. The other thing we did with this study, though, that we realized that would be very important was a series of questions that really they were subjective questions, but it would allow us to get some objective data about how people felt about different problem lists and whether they felt these things were beneficial or not. So I'm not going to spend a lot of time on this, but it wasn't, me and my 3 friends who sat down and looked at these problem lists. We did include 300 physicians, which, really kudos to Jordan and her team to be able to get 300 clinicians to agree to do an unpaid study for participating in this. And as we said, we did not limit it to MDs and DOs. I'm using the word clinician deliberately because we know that it's not only the doctors, it is also any of the physician extenders, as well as nursing who interact with the problem list. So they need to feel comfortable with it as well. We asked them to perform tasks from a traditional view and then an alternate view, obviously not naming which was which. And then again, we evaluated the time. And, we had a time clock on them, but we also gathered some subjective feelings about how they felt during the study and after. So the results were interesting. I have divided them up into both the subjective findings and the objective findings. In the subjective, what we were able to find is that there were some interesting specific frustrations with problem lists. Over half said that just navigating problem lists was too consuming. The traditional format, the reverse chronologic order, was not beneficial, although it sounds like it should be. We all know that we don't always know when a disease started. It's often very difficult for them to say when their diabetes was first diagnosed or their hypertension. A lot of EHR platforms, rightly so, with no other alternative, defaulted to the date it was entered in the problem list. And I can't tell you how often that is not a correct date for when the illness started. People just didn't have confidence in the accuracy of the problem list. It didn't fit into the workflow, because if you had to stall once you got into the room and you found the problem list, you'd have to sit down and take the time to try to digest it. And people just haven't been using problem lists. They've actually, gone to different lists, such as previous assessments lists, reading notes, and for at least a quarter of them, they pretty much abandoned the use of the problem list, which in my opinion, is really a shame. The objective findings that we were able to identify, people were, and this obviously from what we saw, but it's really nice to prove it, they were 63% faster to identify problems that would be in a related group, that were related to each other. And we know that single act alone allows people to really ingest both problems that are relevant to them and the ability to see what is redundant and evolving within any given group. So they were 63% faster and they were 15% more accurate. Those were the 2 big findings that we're able to glean out from them. Some of the other findings were not as statistically relevant, and we're going to touch on some of the problems with the study that we identified in a moment. 23% increase in satisfaction scores for the IMO list over the generic. I think that's a big number. I would like it to have been, higher than that. But again, this was a quick test. This was quick exposure. I think if people lived with that list for, a month or so, that number would be higher. Again, the joke is this is an objective finding from a subjective set of questions. But I've talked to my data scientists here at IMO, and they have assured me that that's an okay thing to say as long as you've explained how you got to that number. So this was a series of questions that we asked, and we rated their responses from 0 to 4, and we created a scoring for each of the problem lists. And as we said, satisfaction was increased 23% for the IMO list over the generic one. So what were some of our conclusions? And I'm not a big fan of reading slides, but I do want to read this slide because I think it's really the point of what we tried to accomplish. Problem lists are a significant source of frustration that provides the providers report as a cause of burnout, and even more so than technology in general. So it's not just, I'm tired of the EHR, I'm tired of computers. I actually get a little bit offended when people say doctors are averse to technological change. I don't think we are. I think we just prefer something that doesn't slow us down, makes us a better doctor, and is really proven to be better than the method that I'm already using. If you can't show me those things, I'm going to stay with what's tried and true until you can prove to me there's a better way to do that. And I think that's what that first statement says. Providers are frustrated by wasted time when dealing with problem lists and problems with inaccurate and redundant issues. I remember looking at a patient I visited at an institution, and the problem list, I believe, was 17 pages long, 17 different scrolls through, and no one's going to look at that. That's just, you might as well not have a problem list on that patient unless it's on the front page, in which case you're going to miss something. Issues with the problem list negatively impact patient care and reimbursement. Again, this came more from the poll questions than it did from the data. We didn't specifically test for reimbursement, but that was certainly something that was first and foremost on many providers' minds, especially if you are in a risk or a capitated environment and dealing with HCC problems. Some of the future-looking questions, if problem lists were better curated, providers would see multiple benefits, patient care being one of them. People are asking about AI. What can AI do for some of this? And it's certainly something as a company we are heavily invested in and looking towards improving some of these workflows. And a categorized problem list did perform better in certain metrics than an uncategorized problem list. Some of the surprises that we found, obviously, that you cannot just evaluate a problem list objectively. A lot of medicine, it would be very difficult to prove that an uncategorized problem list had an adverse effect on patients or a positive effect. There's too many variables. So there really must be a subjective component to any study, and I think that's valid. I don't think there's any problem with that. Subjective information can be very, very accurate, especially if trends are identified. You must create a controlled environment, at least initially. Initially, patients must use this in a controlled environment, or your time metrics will just not be adequate because there's just too many distractions and too many other things going on to know whether the person doing the test caught a phone call, someone asked them a question, a code blue happened on the floor. So we realized we had to move it to a controlled environment very, very quickly. In my opinion, it would have been nice if we could have allowed people to become comfortable with the IMO solution first and then presented them with some of the time metrics and challenges that we gave them. They were learning on the fly during the study. And I think some of the metrics that came back not statistically significant really suffered from the fact that the clinicians were trying to learn and become familiar with the new format instead of just comparing apples to apples. And then the last question is a bit more controversial. Should you have a moderator for the study? Should there be someone there assisting, allowing for questions? I think that can be debated. I'm not a big fan of moderated studies. It's too easy to lead the witness from my days of watching Law and Order. And I'm not a big fan of that. So I would think that I'd still like to do it in an unmoderated fashion, but just to deal for some of the bullet points above. So what's next? We did learn a lot just from not only the data, but just the actual act of carrying out the study. And the first thing is we need to improve the study. So consider moderation and some of the things that I just talked about, really to be incorporated into it. I think we need to expand the study to include, we got so many questions about the cleanup tools, about assessing financial impact. There are other aspects of these tools, such as a tool called Discovery that can find stuff that's missing. And then, as we said, AI is certainly going to play a role. The question is how big of a role. Can AI identify problems that were seen on a specific visit, but were not then charted in the problem list? Can it glean from labs or other procedures that there may be problems missing from the problem list? You had a negative stress test that definitely showed there were some, symptoms of angina or cardiovascular disease, coronary artery disease. Could AI be a useful tool in identifying by reading dictated notes from procedures and op notes? Can it find stuff? Could it read the problem list? Certainly, identifying, we're using some of the tools to identify lapsed problems time-wise and related ones as well. So I think AI will have a role. Again, IMO's, really strict tenet of never making automated changes without at least some, clinical supervision to make the final call. We really feel strongly about that. So there will be a role. How big of a role, yet to be determined. So that's it for the presentation. As I said, we are going to open it up for questions. I hope that was informative and at least did answer some of the questions that people may have about what at least IMO is doing to try to tackle this very real and prevalent problem in the clinical space. And again, I thank you for your time.
Awesome. Thanks, Dr. Rube. Yeah, so at this time, just type your questions into that Q&A box on the bottom of your console. Just excuse any brief silence while Steve and I kind of look at it. Anyways, Steve, so there's
Yes.
a question that came in. So
Yep.
with the ever-growing problem list, how can IMO help providers to bring down, this huge list to be a more streamlined and relevant list?
Absolutely. So again, we kind of divided our approach into the display and the content. And, your question really deals, with how can we deal with all of this extra content. And again, I can't stress from a personal opinion that extra content can be as detrimental as having nothing listed. So we divided it up into, categories of problems that were causing this bloat. One thing that I didn't touch on was problem list reconciliation. Problem list reconciliation, when a patient comes from a different institution and has another problem list, either within the same EHR or a completely different EHR, most EHRs don't have a good ability to reconcile those problems at the point of import. They get dumped into the problem list, and now you've doubled the size of the problem list, again, compounding the problem. We think the IMO tools, some of which I touched on today, really, really do kind of address that. We try not to be obtrusive into the workflow, but it is something that institutions can track when people are disregarding many alerts that say, you have some problem list cleanup. We could tee up the suggestions. These are redundant. These are duplicative. These are probably expired, but it is going to take a clinician of some sort to look at it and go, yes, I want to move this to past medical history, or it was an error. So I think we're getting there. I think we've made some tremendous strides. Keep pushing us, keep asking those questions, and, it'll keep driving us to come up with these tools.
All right. So one question came on, and if it's too technical, Steve, just let me know and we can follow up after. But how do you see your solutions working with Epic Diagnosis Aware Notes?
Yeah, that's probably beyond the scope of my knowledge, as I am not an Epic user. We could probably get in touch with that person directly,
Okay.
and someone explain to me what Epic Aware Notes are, and then I would probably be able to answer that more directly.
Okay. Great.
Yeah. If they could type into the chat a brief explanation of what it was, perhaps I can. I suspect it's something along problem-oriented charting, a nod to our friend Dr. Larry Weed in the 60s, but I think that's what it might be, but not positive.
No worries. All right. When thinking about like problem list governance, who do you think kind of owns the problem list at an organization?
Yeah, $1 million question. I have to put my own biases aside, right? I mentioned that, I practiced as a family physician for many, many years. There are two approaches: people who are going to want governance and people who don't want governance. I think there's never going to be a single answer to that question. I would answer it, and some are going to call this a cop-out, but I think it needs to be shared governance. I think if you're an orthopedic surgeon or a cardiologist or a dermatologist, and your section of the problem list is so cluttered and bloated that it's embarrassing, clean up your section of the problem list. However, as a family physician, you are the captain of the ship, or as a primary care physician. And therefore, it is ultimately your responsibility. At least this is the way I approached it. It was my responsibility to understand every aspect of the patient's condition. Therefore, the overall list should come under my purview. Does that mean that I would call up my cardiologist and say, hey, could you clean up your area of the problem list? Maybe. That's one approach. But I think it is going to be shared governance. I think that we've been dealing with this question for so long. I think it's not a question that can be answered to say this person is responsible. I think, though, that the most common answer is that it probably is the purview of primary care physicians. But as I said, I think it needs to be shared.
Awesome. All right. With that question, what would be your advice to providers to take home today?
Um, you're still doing very noble work. It's still the best profession that I know of. It is frustrating at times. Don't get frustrated. The statement I've often made, if I was still practicing today, is a lot of the rules that are placed upon us are great if you see one patient a day. Unfortunately, most of us cannot function on seeing one patient a day, and so we do need to deal with this. These changes are coming. These regulations are happening. But it's not just a regulatory thing. I think that this technology, starting with the electronic medical record, they really do have the potential to improve not only patient care, but the doctor's ability to deliver healthcare and to make wise questions and present them with data. So I think what the message I would take home is I think we are advancing as an industry. I think it's improving dramatically from where it was 10 years ago. I think it'll continue to improve exponentially fast. Personally, always be leery of new technology, but don't necessarily shun it. Really, approach everything that, how can this benefit me? How can this make me a better clinician? How can this improve things for the patient? And I think we will continue to grow as an industry.
Great question. All right, hold on. I'm going to read through this last one.
Okay.
All right, so our practices providers struggle to utilize the problem list at all. Most patients have a blank problem list. They feel it is duplicate work when they are already adding assessments to the visit. When we've tried to show and exploit the features of IMO Core that make it easy to add assessments and problems together, do you have any insight or advice on practices who have been successful with the provider buy-in on using the problem list at all?
That's a great question. That's also a tough question. Because there's clinicians are hyper aware to duplicative workflows right now because we are being asked to do so much. And making the argument that this is not truly duplicative, as I would say, every assessment does not belong on the problem list, and everything on the problem list doesn't necessarily was an assessment at a visit. So they are two different parts of the workflow. A patient who came in, with a minor abrasion that, healed in 2 or 3 days does not necessarily belong on the chronic, patient problem list. Something that was diagnosed due to a test and you have yet to see the patient for, but was identified, may belong on the problem list, but was never an assessment. So sometimes it really is about sitting down and gentle education about why these two things are not truly duplicative. But again, it really is upon us as an industry. Where can we improve these things? Most EHRs do have the functionality of quickly moving, even if you take IMO out of the picture, of quickly moving today's assessment to the problem list or not. That adds one click. I'm not sure, that's a lot to ask. Many institutions have efforts underway to look at past assessments and try to pre-populate a problem list for a clinician when possible. I think using the tools of the EHR for moving things easily back and forth, if something's on the problem list and that's going to be your assessment for the day, that saves you time. Having that might be the best argument to make is that overall, while there is work up front, you will reap the benefits down the road from an intact problem list by able to moving those things to today's assessments, by more quickly understanding what the patient's clinical picture is, that overall you will benefit both time-wise and quality-wise if you have an intact problem list.
Awesome, thank you. Okay, I'm trying to decipher this question, but at the VA, they have to code twice, ICD-10 and SNOMED.
Yeah.
The ICD-10 coding system is divided as is, but only allows one designation. Sorry.
Yeah, probably one code per problem. I think
Yes.
You get the question.
EHRs need to integrate problem identification coding to the problem list. This is an EHR issue in programming and coding. I
Yep.
think this is more like a
Well, the answer to your question is IMO eliminates all of that, and the VA is in the process of changing systems. We are heavily integrated with Oracle Cerner, Oracle Health, but IMO does not require clinicians to pick an ICD-10 nor a SNOMED code. That is our job. IMO allows a clinician to pick a clinical term, and then those codes follow silently both ICD and SNOMED, and as many codes as necessary are metadata in the background. We do not use crosswalks. We code to each set individually, and IMO becomes the source of clinical truth, and then you expose the code set needed. So I sympathize with you. I have been to here. I'm based in Chicago. I've been to the Great Lakes, hospital up there, the naval base, and they struggle with that. IMO was created to solve that exact problem 20 years ago, was to allow clinicians to just pick clinical terms and not require them to become coders, and the codes follow silent.
Awesome. Thank you, Steve. All right, so we're going to go ahead and close out today. I really hope that you found everything useful in this webinar. Steve, you did a wonderful job. Thank you
Thank
again.
you.
And be mindful that the recording is coming to you. So if you want to refer back to it, you can. Check us out on our website. We launch new blogs every week, and we try to keep the industry really informed at imohealth.com. But anyways, I hope you guys have a great rest of your day, and thanks again for coming.
Take care. Thank you for your time.